Again, Professor Nick from Brooklyn, New York, or Nick Nicole. I'm physician assistant, and these lectures are designed for PA board review examinations. PAs and MPs are both mid-level providers. We'll discuss here part of the GA part of GA system, which involves small intestine and colon. Let's start from the first slide. First slide. We talk about it's a small intestine and colon, and we talk about malabsorption. This slide, the celiac malabsorption is the most frequent cause of celiac disease. It can be presented in adults. Chronic pancreatitis is also very similar presentation and presents with fat malabsorptions. Rare causes are tropical sprue and Whipple disease. All of these, 4 of them presents with steatorrhea, defined. The stool is defined as oily, greasy, floating, and foul-smelling. All the forms of fat malabsorption are presented with deficiency of fat-soluble vitamins such as A, D, E, and K. And there is on the left upper corner, left lower corner, there is a clinical tip which states that fat malabsorption frequently presents with weight loss. There is a couple of deficiencies which we want to discuss on the right side of the slide, and their clinical manifestation. The first deficiency, this is vitamin D, and usually vitamin D presents with hypocalcemia and osteonecrosis. Vitamin K deficiency presents with bleeding and easy bruising, and vitamin B12 deficiency presents with anemia, hypersegmented neutrophils, and neuropathy. On the right lower corner of this slide, there is a clinical tip which states that vitamin B12 needs intact bowel wall and pancreatic enzymes to be absorbed. Let's go to the next slide. This slide, slide number 3, discuss that clinically we cannot distinguish tropical sprue from celiac disease, which is gluten-sensitive enteropathy. Celiac disease gives in 10% so-called dermatitis herpetiformis. Let's talk about Whipple disease. Whipple disease is frequently presented with arthralgias, 1, 2, ocular finding, 3, neurological abnormalities like dementia seizures, D, fever, E, lymphadenopathy, and F needs to be treated with ceftriaxone, following with trimethoprim sulfamethoxazole. The diagnostic test for this disease is very questionable. So one of the main distinction between chronic pancreatitis and gluten-sensitive enteropathy, this is presence of iron deficiency. This is because of the iron needs of intact bowel wall can be absorbed, but we do not need pancreatic enzyme to be absorbed. So for absorption needs intact bowel wall, but pancreatic enzymes are not necessary. Let's go to celiac disease. Unique tests. The first test, this is anti-tissue transglutaminase, number 1. Number 2, anti-endomyosomal antibody. And number 3, IgA anti-glidin antibodies. Here in this slide, slide number 4, we are saying that the most accurate diagnostic test for celiac disease is small bowel biopsy, which shows flattening of the villi. Whipple disease and tropical sprue is also most accurate diagnostic, with the bowel wall biopsy showing a specific organism. Here's the clinical tip, which states that bowel biopsy is essential in celiac disease to exclude lymphoma. Let's go to the next slide. Next slide is this so-called lactose intolerance. This is slide number 5. In lactose intolerance, there is no weight loss, and is usually, if there is no weight loss, it usually is associated with lactose intolerance because of the lactose, the one and only of the sugar, several sugars to be absorbed. Lactose intolerance does not alter the absorption of any other nutrients such as fat, and there is no deficiency in calories. All the vitamins are absorbed normally. The stool osmolarity is increased, but the usual way to make the diagnosis is simply to remove all the milk containing products from the diet and wait for a single day for resolution of the symptoms. Avoiding milk products except yogurt is the therapy. Usually oral lactose replacement is also good therapy and is available over the counter. Let's go to the next slide, number 6. In this slide, we need to discuss irritable bowel syndrome, or IBS. This is a syndrome of pain when it's associated with diarrhea, constipation, or both. There is no specific diagnostic test. It's usually a diagnosis of exclusion. Because of it is diagnosis exclusion with association with a complex of symptoms. IBS is not associated with weight loss. Pain does not automatically mean malabsorption. There is a clinical tip here that IBS is not associated with blood or white cells in the stools. So in IBS, don't expect to see blood or white cells on the stool sample. The pain in IBS is, number one, relief by a bowel movement. Number two, less at night. Number three, relief by a change in the change of bowel habits, such as diarrhea. Let's go to the next slide, which is slide number 7. Here in this slide, we'll discuss the treatment of IBS. Usually, fiber is the diet, number one. Number two, antispasmodic agents such as lacoxamide or hyostigmine. Also, number three, tricyclic antidepressant like SSRIs or amitriptyline. Additional therapy is when you have a diarrhea predominant IBS. In this case, we may use rifaximin, which is non-absorbed antibiotic with modest effect in diarrhea predominant IBS. Also, we can use allocetrone, which is inhibitor of serotonin with modest effect in IBS. You need a special permission to use it. Also, number three, this is Eluxadoline, which is mu-opioid receptor agonist for diarrhea like IBS. Relieves the pain and slow the bowel. And the last one is probiotics. The mechanism of action is unclear, and usually don't choose it on a clinical vignette. Next, we need to talk is about additional therapy for constipation predominant IBS. In this case, number one, we can use fiber. Number two, we can use PEG, which is polyethylene glycol, which is a non-absorbent bowel lubricant. Also, we can use number three, 2-B-prosterone, which is chloride channel activator. Note that if PEG does not work, you can use this medication. And number four, this is linaclotide, which is guanylate cyclase agonist. Wow. And you can use it if PEG does not work. Let's go to the next slide. Next slide is a review. There is a review table of the differences between CD or Crohn's disease and UC, which is ulcerative colitis. Let's start from CD. CD usually we have skip lesions, number one. Number two we have transmural granulomas. Number three we have fistulas and abscesses. Number five, masses and obstruction. And number six, perianal disease. So this is the main features of Crohn's disease: skip lesions, transmural granulomas, fistula and abscesses, masses and obstructions, and perianal disease. In contrast, UC or ulcerative colitis, number one, can be curable by surgery. Number two is an entirely mucosal problem. Number three, no fistulas, no abscesses. Number four, no obstruction. And number five, no perianal disease. And here we have a clinical tip. A frequent question: when should screening occur? The answer is after 8 to 10 years in colonic involvement, with colonoscopy every 1 to 2 years. So once again, when you should screen: after 8 to 10 years, when the colon is involved, and the way how you do it is colonoscopy every 1 to 2 years. Okay, so let's go to the next slide. This slide discusses the diagnostic tests for these clinical problems. Here the slide states that endoscopy is the most accurate test when the disease can be reached by a scope. For CD, this is mainly in the small bowel. Radiological tests such as barium study to detect lesions, and when the diagnosis is still unclear, serological testing may be helpful. OIBD is associated with anemia. On the right side of this slide, we have a table where it differentiates ANCA and ANSA between Crohn's disease and ulcerative colitis in the case of IBD. ANCA, or anti-neutrophil cytoplasmic antibody. Crohn's is negative, CD is negative, and UC is positive. In ASCA, or anti-Saccharomyces cerevisiae antibody. Wow, very difficult to pronounce with my accent. The CD is usually positive, and UC or ulcerative colitis is usually negative. Okay, very good. Let's go to the next slide, slide number 10. We're almost done. The treatment of both CD and UC, it depends what you have. If you have acute exacerbation, usually they're treated with steroids. Chronic maintenance of remissions is usually with 5-ASA derivatives such as mesalamine. Anacol or besalamine is used for UC, and pentaz or also mesalamine for CD. Rovaza, which is again mesalamine, is for UC largely limited in the rectum. Steroids which are used are prednisone or budesonide. Here we have to note carefully that azathioprine and 6-mercaptopurine are used to wean patients off the steroids when the disease is so severe that severe recurrences develop as the steroids are stopped. Everyone needs calcium and vitamin D, all the patients. Perianal CD is treated with cipro, fluoxetine, and metronidazole. Fistulas and severe disease unresponsive to other agents are treated with TNF or anti-tumor necrotic factor. Agents such as infliximab. Surgery is done for fistulas only if there is no response to anti-TNF agents. Neither form of IBD is routinely treated with surgery. UC can be cured, however, with colectomy. In CD, surgery is used exclusively for bowel obstruction. CD will tend to recur at the site of the surgery, and we need to know that if the disease is refractory of all other treatments, we have to give another agent which is called vedolizumab, which is alpha integrin inhibitor. Here there is a clinical tip which we have to remember. Budesonide is a steroid specific for IBD. The first pass effect is good for EBD treatment. Wow. Let's go to the next slide. The next few slides. The last two slides, we'll talk about diverticulosis and diverticulitis. For the first one, diverticulosis is when you have outpocketing of the colon. It's so common that the standard meat-filled diet has to be routinely expected in those above 65 or 70 years old at age. Vegetarians already develop diverticulosis. We need to know that diverticulosis is asymptomatic mostly of the time. Patients may be presented with left lower quadrant abdominal pain, constipation, bleeding, and sometimes infection or diverticulitis. The most accurate test is colonoscopy. Barium studies are accepted, but not as accurate. Brown, physium, methylcellulose, and increased dietary fibers are used to decrease the rate of progression and complications. Diverticulosis is the most likely. This is the most likely diagnosis question, if it is, which is easily answered when presented with an older patient with the following presentation. Number 1, left lower quadrant pain and tenderness. 2, fevers. 3, leukocytosis. And 4, palpable mass sometimes. Here we have a clinical tip which states that colonoscopy and barium enema are dangerous in active diverticulitis because of increased risk of perforation. Infections also weaken the colonic wall. Diverticulitis is the most likely diagnosis question when it is very easy to answer when presents in older patient with the following: left lower quadrant pain and tenderness, number 1, number 2, fevers, number 3, leukocytosis. So fever, leukocytosis, and palpable mass sometimes. Symptoms such as nausea, constipation, and bleeding can be presented also, but they are not too specific. The best initial test is a CT scan. And let's go to slide 12, which is the last slide. The treatment of diverticulitis is with antibiotics which cover E. coli and anaerobes, and they are presented in the bowel such as ciprofloxacin combined with metronidazole or beta-lactamase combinations such as amoxicillin clavuronate, ticarcillin clavunate, or piperacillin tazobactam, or ticarcillin clavuronate. The other antibiotic which is used, this is anterpenem or carbapenems. Surgery is the answer when there is if there is no response to medical therapy, frequent recurrence of infection, perforation, fistula, formation, abscesses, stricture, or obstruction, surgery is the answer. So which is the indication for surgery? That's young or old patients. So the answer is the younger patients should have a colon resected more often because of the greater total number of recurrence episodes will occur. The particular disease does not disappear despite treating episodes of diverticulitis. So diverticular disease does not disappear despite treatment episodes of diverticulitis or the use of fiber in the diet. So diverticular disease does not disappear despite treating episodes of diverticulitis or use of fiber in the diet. And clinical tip is when patients with acute diverticulitis should not be fed. And this is the end of the chapter number 2. This is Nick, the PA from Brooklyn, New York. Have a nice evening. Thank you.